We're pleased to welcome today's speaker, Heather Dunlap, who will guide us through the key changes, implications, and what you need to know about the 2026 CPT updates. Heather is a manager at Kohler Healthcare Consulting. Her tenure in the healthcare industry exceeds 2 decades, with a focus on critical areas including coding, compliance, audit reviews, billing, and resolving insurance denials. Heather demonstrates proficiency in establishing coding guidelines and systems, including E&M, CPT-4, HCPCS, and ICD-10-CM. Heather is a certified professional coder, certified documentation expert outpatient, certified risk adjustment coder, certified evaluation and management coder, and certified hematology and oncology coder. With that, I'll turn it over to Heather.
Thank you, Kalita. Okay, just to jump right into this because there is a lot of information here, so these slides will be sent out to you. So this is just about me. Here are disclaimers. I do want to point out the first one. We will not discuss every code and or description in detail. There's a lot and we would be here for a very long time. So just keep that in mind that not every change will be discussed. So our objectives for this session is to review the 2026 CPT editorial changes and break down the what and the why for the major updates. Let's take a look at the agenda for today. We are going to go over, have an overview of the changes, and we are going to review the updates for E&M and digital medicine, vaccinations and immunizations, updates by system, and some Category 3 code updates. So here's a look at the 2026 update by numbers. There are a total of 11,525 codes in the 2026 code set. There are 288 additions, 46 revisions, and 84 deletions, which totals 418 editorial changes. It is a heavy lift that went into effect January 1st, with some codes available for use beginning mid-2025. This table just shows the changes by areas. It just shows who had the most changes, who had no changes, editorial changes for added, deleted, and revised. So the major changes for 2026, introduction of new codes for remote patient monitoring to report periods of shorter durations. New dedicated codes have been established to report scalp cooling treatments. An introduction of new codes for hearing device services, and the lower extremity revascularization has been completely restructured with 46 new codes that replaced already existing codes, and we will go over those. So to jump right in for evaluation and management and digital medicine. So starting with remote monitoring, this brings the clinic to the patient. It allows physicians to track and assess health data without the patient ever having to step foot in a clinic. Remote monitoring services are broken into 2 categories. Remote physiologic monitoring, or RPM, and that's for the body's vitals such as blood pressure, weight, and heart rate. And remote therapeutic monitoring, or RTM, for treatment impacts such as pain management and therapy adherence. The biggest change is the introduction of codes for patients who do not need or cannot maintain a full month of monitoring. CPT code 99445 is a new code, and it is a game changer for patients with shorter monitoring needs. It covers the 2 to 15-day window for device supply and daily recordings. Previously, if a patient did not hit 16 days, you could not bill for the device at all. So this just fills in that gap. A new code 99470 covers the first 10 to 19 minutes of monthly management time. Like the longer codes, it requires at least one real-time interaction, like a phone call or video call, with the patient and or caregiver. And again, it fills in the gap for those light touch patients who need oversight but don't quite reach the full 20-minute threshold. Code 99453 is revised, and this is going to be the setup code to report setup for as few as 2 days of monitoring. 99454 for device supply monitor or device supply monitoring of 16 to 30 days. And that still remains your go-to code. So while the it was revised, it's still pretty much the same. And codes 99457 and 8 for management. These still cover the initial 20 minutes and subsequent 20-minute blocks. So updates for remote therapeutic monitoring, they offer more flexibility by lowering the minimum days and time required for billing. These new codes fill a gap for patients who provide data for less than the traditional 16-day minimum. New code 98984 for respiratory. This covers the device supply and data transmission for 2 to 15 days within a 30-day window. 98985 for musculoskeletal covers 2 to 15 days of device data. And 98986, new supply code for 2 to 15 days of cognitive behavioral therapy data monitoring. The expanded treatment management codes, CPT 98979, it allows you to bill for 10 to 19 minutes of monthly management, and this captures revenue for partial month patients or those needing less intensive oversight. Revised codes 98980 and 81 will remain your primary codes for 20 plus minutes of management. And also revised codes 98976 through 8. The descriptors for these existing device codes now specify they are for the full 16 to 30-day monitoring period. This is just a table that kind of lets you see it a little bit easier. So codes were created for both RPM and RTM to report device supply monitoring of less than 16 days and report management services requiring less than 20 minutes. Again, just easier to look at tables. So the new structure for the RPM and RTM codes. For RPM, the code 99470 is now the primary parent code, with 99457 and 8 serving as the child codes. And we see the exact same logic applied to RTM, where 98979 has become the parent code for 98980 and 81. So starting in 2022, mechanical scalp cooling was initially tracked using temporary category 3 codes 0662T and 0663T. However, the service has officially graduated to the category 1 code set. Just a little about the scalp machine-based scalp cooling. It is a key approach for managing chemotherapy-induced alopecia. To properly report these services, the device must be FDA cleared and operated by trained staff under professional supervision. Note that these are designed for clinical, office, or facility settings, not for home use. 97007 will be reported once per chemotherapy period. It covers the dedicated visit for custom cap fitting, the supply itself, and patient education. And clinical staff can handle this independently once the physician or QHP orders the cooling. 97008 is your per session code. It kicks in 30 minutes before chemo starts and covers the cooling process through the end of the infusion. And 97009, this is what you're going to use if the cooling continues after the chemo ends. Just remember, don't bill if the post-chemo cooling lasts less than 16 minutes. Appendices P and T have been expanded to include more behavioral health services recognized for audio, video, or audio-only delivery. Appendix P, which is audio video telemedicine, covers list codes for real-time synchronous audio video telemedicine. that can be billed the same as in-person services. And Appendix T, which is audio-only telemedicine, lists codes for services that can be provided via audio-only technology. And this is crucial for reaching patients in rural or underserved areas. These updates primarily focus on increasing access to behavioral health and developmental testing services. 13 existing codes from the medicine section were identified as services that may be reported via telehealth, and telemedicine symbols were added to these codes and placed in the appropriate appendices. CPT 96112 and 3 are listed in Appendix P, meaning they are approved for synchronous audio video telehealth. They are not permitted for audio-only services. 96112 covers the first hour of developmental testing, including administration, scoring, and reporting. And 96113 is the add-on code for each additional 30 minutes. These must be interactive video sessions, not just phone calls. Excuse me, psychological and neuropsychological and group services, codes 90853 for group psychotherapy and 96202 through 3 for group caregiver training are approved for both Appendix P and Appendix T. Similarly, 96130 through 33 for evaluation services and 96136 through 39 for test administration are approved for both audio video and audio only. And just make sure that you always verify with specific payers, as they may have stricter rules than the CPT guidelines. We know that payers are not always do not always think the same as everybody else. So just make sure we want you to get paid for what you do. So just make sure that before you start billing these codes, just make sure you check with the payers. There are numerous vaccine updates, so we are not going to go over each one of these. These are just the new codes. I do want to bring attention to your little lightning bolts over here. Just make sure that before you start billing these codes, they are FDA approved, because right now, since they still have the lightning bolts, they are still pending FDA approval. So new immunization and counseling codes. These codes address the vaccine hesitancy. We have 3 new time-based codes, 90482 through 84. Excuse me. These are specifically for those moments when the clinician provides immunization counseling, but the patient ultimately decides not to get the shot that day. Whether you're speaking with them in person, or video or over the phone, you'll choose the code based on how long you spent educating them. 90482 for a quick 3 to 10 minute talk, 90483 if the discussion goes between 10 and 20 minutes, and 90484 for those deep dives exceeding 20 minutes. 90480 has been updated to cover the administration and counseling for the primary or only component of a COVID vaccine. However, if you are dealing with a combination vaccine like COVID plus flu, you'll now use the new add-on code as well, 90481 for that extra component. And this is just a new immunization code for the RSV influenza. Like I said, that's just a new immunization code. So moving on to cardiology. So we have 2 new crucial PCI codes to better reflect complex work. First, CPT 92930 is specifically for complex multi-lesion or bifurcation stenting, where the side branch is actively treated. Documentation must show separate, non-overlapping stents and not just a protected wire. Second, CPT 92945 arrives for CTO revascularization, specifically covering procedures using both antegrade and retrograde approaches, including any combinations of stent, atherectomy, or angioplasty. Revised base codes 92920, 24, 28, 33, 37, 41, and 43 now include branches in their descriptors. And this just allows for comprehensive reporting of an entire vessel or territory using a single primary code, eliminating the need for separate branch add-on codes. 92972 for intravascular lithotripsy, and it's now a permanent Category 1 add-on code for coronary lithotripsy, and you will report it alongside primary codes like 92920, 28, or the new complex PCI code 92930. 92973 has been revised as mechanical aspiration thrombectomy to better align with the current techniques. And this update ensures that it integrates seamlessly with the newly reorganized 2026 PCI code family. 93571 and 72 for the intravascular Doppler flow has been updated to include when performed regarding pharmacologically induced stress. And this just clarifies that induced stress is no longer a strict requirement for reporting these measurements. Two new Category 3 codes, 0948T and 0949T, were designed for remote monitoring of cardiac contractility modulation, or CCM systems. These codes cover up to 90 days of surveillance. Specifically, 0948T is used for the professional analysis and report, while 0949T covers the technical component, including data acquisition and technician review. Effective July 1st, 2025, three new Category 3 codes were introduced specifically for wireless inferior vena cava, or IVC, sensor implantation and hemodynamic monitoring. 0981T for transcatheter implantation of a wireless IVC sensor for long-term hemodynamic monitoring. 0982T for initial setup and patient education, and 0983T for ongoing remote monitoring of an implanted IVC sensor for up to 30 days. So moving on to GI. So ESG is finally stepping out of the unlisted category and has moved from the vague 43999 code to a specific new Category 1 code 43889. We have a new Category 1 code for reporting non-implanted PENFS. It is CPT 64567, and this officially replaces the old Category 3 code 0720T, which has now been deleted. For colon motility services, codes 91120 and 91122 are officially retired. They've been replaced by two more specific codes, 91125, which covers anorectal manometry, including rectal sensation and balloon expulsion, and 91124, which is dedicated specifically to Barostat studies. And this will just provide cleaner data and more accurate reporting for motility labs. Let's take a look at some new Category 3 codes. We now have 0963T for anoscopy with submucosal injection, and 0977T, which launched in July 2025 for upper GI blood detection capsules. And lastly, for procedures involving muscle progenitor cell injections into the external anal sphincter, you will use code 1001T. And moving on to general surgery section. Code 0967T became effective in July 2025. It finally gives us a way to report the insertion and monitoring of colorectal anastomosis protection devices, a service that previously had no specific code. Next, we have CPT code 0972T. This is a new Category 3 code designed specifically for AI-driven algorithms to classify burn healing. It is an all-inclusive code, meaning it covers the entire workflow from the initial system setup and image transmission to the final generated report. Effective July 2025, Category 3 code 0973T through 76T are introduced for selective enzymatic debridement of burn eschar, specifically for procedures requiring anesthesia. The new code set distinguishes between general areas like trunk and limbs and complex areas like the face, hands, and feet. They are billed in 100 square centimeter increments, which means we no longer have to rely on those broader, non-anesthetized codes. Codes 1013T to 1018T now specifically address lower esophageal sphincter neurostimulation. This group covers the full life cycle of the device. 1013T is your primary code for implantation. Codes 1014T and 15T handle any necessary revisions or removals of the hardware. And finally, the last three codes, 1016T through 1018T, are dedicated to electronic analysis, distinguishing between intraoperative work and subsequent follow-ups with or without pre-programming. Code 1019T is our new Cat 3 addition for lymphovenous bypass. It is a comprehensive code that bundles the microsurgical work and the vascularized transfer. Plus, if the surgeon uses robotic assistance, that's now baked into this single code. We also have a dedicated code for active thoracic irrigation, 1021T, and this addresses a gap in reporting as no specific code existed for this procedure prior to 2026. Previously known strictly as acne surgery in the INTEG system, CPT code 10040 has officially been rebranded to extraction. This update removes the acne-only restriction, so you can now use code 10040 for extracting various lesions like milia or cysts, regardless of whether the patient has acne or not. For path and lab. So we have a new streamlined code for combined rapid test. CPT 87812 replaces billing for 87811 and 87804 separately for COVID and flu AB combos. This applies specifically to rapid antigen tests read by direct visual observation. The documentation must support the visual nature of the test. Two new CPT codes, 87182 and 87183, focus on carbapenem-resistant enterobacterialis, or CRE, testing. These tests are vital for identifying resistance in bacteria like E. coli and Klebsiella, helping clinicians pivot to alternative treatments like colistin or tigecycline. 87182 is for enzyme detection, and 87183 is for resistant gene detection. For microbiology, CTC or CPC 87494 is your new 2-for-1 code for chlamydia and gonorrhea. Instead of billing two separate codes, use the 87494 for any multiplex amplified probe test that detects both pathogens at once. 87627 covers high complexity panels for joint infections. It is a one-stop report for joint fluid samples, detecting a broad range of pathogens and crucial drug-resistant markers. This change is designed to get faster, more specific results for patients with joint space infections. Moving to chemistry, CPT codes 83015 and 83018 for heavy metal testing have been revised to include specific examples, notably antimony and gadolinium. 83015 is used for the qualitative screening, while 83018 is used for the quantitative analysis. Starting this year, we have a new Category 1 code, 81524, and this covers advanced DNA methylation profiling for central nervous system tumors. It is important to note that if you're using this code, it already includes the analysis for MGMT promoter methylation, so there is no need to code that separately. When it comes to billing for optical genome mapping, we've moved to CPT 81354. This new code covers the full genome-wide picture, specifically for constitutional abnormalities, and accounts for both copy number and structural variant analysis. Code 0961T for shortwave infrared exam is a per specimen add-on service used specifically during the gross examination of surgical pathology service or specimens. It must be reported in conjunction with primary codes 88307 or 88309. And this imaging provides an enhanced layer of visualization for locating nodes within complex fibroadipose tissue. For PLA codes, we are not going to go over these. So this category accounts for the largest number of new codes, around 27%. A substantial portion of the new codes are PLA codes, covering tests for conditions like preeclampsia, solid tumors, and respiratory infections. And all of these PLA changes can be found on the AMA website. So moving to neurology. Code 62287 has been relocated to the new percutaneous decompression subsection to emphasize its use for needle-based procedures. A key change to the descriptor is it now explicitly includes any discography or epidural injections done at those same levels. It's essentially an all-inclusive code for those specific services now. Code 63032 describes the repair of an annular defect using a bone-anchored device. And note that this add-on code should be used in conjunction with 63030. Under the new guidelines, you should only report this once per operative session. It is also important to note that all intraoperative imaging where required to place the device is considered inclusive to 63032. Codes 61624 and 61626 have been updated to include all necessary imaging services. This means you no longer bill separately for things like radiological supervision and interpretation, interprocedural road mapping, or imaging guidance. It is all now bundled into the primary procedure code. We have 5 new Category 3 codes covering the full life cycle of the subscalp continuous EEG, from initial implantation to any necessary revisions or removals. Because these are Category 3, our documentation needs to be exceptionally precise. Clear anatomical and procedural details are vital if we want to see these eventually transition to permanent Category 1 status. We have a new subsection in the CPT manual, implantable subscalp continuous bilateral EEG monitoring system. It introduces 6 new Category 3 codes, specifically 1004T through 1009T, which we'll use to report the programming and data collection for these devices. 0997T and 0998T were added to the billing coding section for transcranial magnetic stimulation as a treatment of depression and other psychiatric and/or neurologic disorders. Codes 0984T through 87T are used to report intravascular optical coherence tomography imaging for both extracranial and intracranial vessels. These Cat 3 codes allow us to document high-resolution imaging of cerebral blood vessels, typically performed alongside neurointerventional procedures. Starting in 2026, we now have new Cat 3 codes 0968T and 0969T, specifically for the insertion, replacement, and removal of an epicranial neurostimulator system. Prior to this, there were no dedicated codes to report these procedures. For ophthalmology, CPT updates for 92284 through 8 range focus on dark adaptation measurements, specifically introducing a new screening code and potentially revising existing guidelines. So new code 92288 for screening dark adaptation measurements, such as rod recovery intercept time, includes interpretation and report. Because this is a screening, Medicare has declined to recognize or value this code. So just because Medicare does not accept it does not mean other payers will not accept it. So again, just make sure you check with the payers before billing or not billing this code. And 92284, this code remains for diagnostic dark adaptation eye exams using a test device. Moving to orthopedic surgery. So the big update. So recent AMA CPT guidelines have clarified how we code for SI joint infusions. So the main thing to remember now is, does the device pierce the cortical bone? Code 27278 you will use for intra-articular devices. These sit inside the joint but do not break through the hard outer layer of the bone. Code 27279 will be used for transarticular devices or any device that does pierce the cortical bone of the ilium or sacrum. If you are using both types of devices and at least one of them pierces the bone, default to 27279. Both codes already bundle in your imaging guidance and any bone grafting that you do, so that will not be billed separately. Code 1003T covers a full replacement of the thumb space joint or the CMC joint. It involves using artificial parts to replace both the trapezium bone and the metacarpal bone. Deleted codes 27445 and 27468 were retired to low usage. They were deleted and are no longer valid after December 31st, 2025. CPT 27458 is a new code. It's specifically for one-sided femoral osteotomies where we insert an externally controlled lengthening device. It is a one-stop code, meaning it bundles everything from initial surgical plan and imaging to the actual device management and follow-up care for 90 days. A similar new code was added for the tibia. 27713 is the new standard for unilateral tibia lengthening. It covers the osteotomy and the insertion of an intramedullary lengthening device. Just like the new femur code, this one is all-inclusive. It bundles the pre-surgical planning, the alignment assessments, and the device adjustment schedules all into a single code. We now have a specific code 64728 for ultrasound-guided balloon dilation of the carpal tunnel. This percutaneous method is a less invasive alternative to the standard open or endoscopic procedures. Otolaryngology. So we have some new CPT codes specifically for air conduction hearing aids that help us break down the patient journey. First, we have the candidacy evaluation, device selection, and fitting and follow-up have been separated into distinct steps. Verification services 92636 through 42 includes specific codes for probe microphone verification, behavioral verification, and supplemental technology fitting. And these codes cover complexity from initial assessment, counseling, and device type determination to post-fitting care. And this is just a new table for the hearing device services, which is available in the special otorhinolaryngologic, I'm sure I said that wrong, section. It details the categories, codes, and times, and is located under the evaluation and therapeutic services. And these are just the codes for the same section that were deleted due to the creation of the new codes. We now have 5 new category 3 codes, 0951T to 0955T, to specifically cover active middle ear hearing implants. These codes track everything from initial implantation and revision to full removal. It is important to note that while existing codes often involve partially implanted devices, this new set is reserved exclusively for fully implanted systems. To better report treatments for snoring and obstructive sleep apnea, the AMA has introduced codes 0978T to 0980T, which covers submucosal cryolysis therapy, which is a procedure that shrinks tissue using freezing technology. Each code identifies exactly where the treatment is applied, whether it's the soft palate or the base of the tongue. Um, Moving on to radiology, we have three new Category 1 codes for 2026 that streamline how we report CTA and cerebral perfusion. 70471 is your new all-in-one code for CTA of the head and neck with contrast. 70472 is your new add-on code for cerebral perfusion analysis. Notably, it is now a permanent Category 1 code, finally replacing the long-standing temporary code 0042T. And you will use 70473 when perfusion analysis is done on its own, meaning without concurrent head CT or CTA. The AMA has officially promoted coronary plaque assessment to a Category 1 code, 75577. This new permanent code replaces the temporary 3 Category 3 tracking codes of 0623T through 0626T, validating the clinical use of AI-enabled quantification in routine practice. We are seeing a significant shift in how we code for radiation delivery. Codes 77402, 77407, and 77412 have been restructured into levels 1, 2, and 3. Level 1 is your simple 2D therapy. Level 2 covers intermediate complexity, and level 3 is for your complex multi-isocenter cases. Guidance and motion management are now bundled parts of the delivery service. And these just are the deleted codes that have been replaced with the codes on the previous slide. CPT code 75842, which covered bilateral selective adrenal venography, has officially been deleted for 2026. We have two new Cat 3 codes for percutaneous laser ablation of breast tumors. You will use 0970T for each benign tumor treated. If you are treating malignant tumors, use 0971T, which is reported once per breast, even if multiple tumors are treated. A major point to remember is do not report separate imaging guidance codes, as this is also a bundled codes. We have three new add-on codes, 1022T and through 1024T to track when we use percutaneous tissue displacement during ablation. 1022T is for abdomen or pelvis. 1023T is for the chest, and 1024T is for soft tissue. New code 1025T for planning tumor-related tumor treating fields therapy. It covers the work of mapping out exactly how to aim electric fields at a tumor and its surrounding edges to make sure the treatment is as precise as possible. Moving to vascular surgery. New code 33882 specifically covers endovascular repair of the thoracic aorta using a branched endograft multi-piece system. Additionally, for cross-carotid revascularization without a native vein, use code 35602, which covers the entire procedure from exposure to anastomosis. Codes 33880 and 1 are now fully bundled, meaning they include everything from pre-procedure sizing and device selection to all imaging guidance. Additionally, the term descending has been removed from the subsection and code descriptors, which broaden their use for the entire thoracic aorta rather than just one segment. In addition to 33880 and 1, codes 33883 and 86 have been updated to include all imaging guidance. These are just the deleted codes related to thoracic endograft support procedures and associated imaging. that has been deleted and replaced by newer revised codes that bundle these services. And here's just more codes that were deleted. We are seeing a major shift in the surface radiation therapy landscape. The goal here is clarity, better reporting for planning, delivery, and energy levels. We are moving away from the outdated 77401 and the Category 3 code 0394T and replacing them with a new streamlined family 77436 through 39. 77436 is your new foundation for planning and simulation. For delivery, we now differentiate by energy. 77437 is for superficial delivery up to 150 kV, and 77438 for higher energy ortho voltage treatments. And finally, there's 77439, which is an add-on code for ultrasound guidance. Just remember, it is reported only once per course of treatment and must be paired with your delivery code. Baroreflex activation therapy, or BAT, is hitting a new milestone. We now have 8 dedicated CPT codes, 6 in surgery and 2 in medicine, to streamline how we bill for both the implant and follow-up care. We are moving away from the old 0266T to 0273T series. Now you will use the permanent code range 64654 to 64659. These new codes specifically cover the implantation, revision, and removal of the system's carotid sinus leads and pulse generators for patients with heart failure or resistant hypertension. New codes 93145 and 46 are exclusively for when interrogation and programming occur on a different date than the initial implant or revision. If these services happen during the same session as the surgery, they are bundled into the surgical codes mentioned on the previous slide. And these are just the deleted codes that were replaced with the permanent codes on the previous slides. Category 3 code 0631T has also been deleted and replaced with the new codes for BAT. Because no existing CPT codes accurately capture the work involved in aortic wall stabilization drug delivery, we now have 2 new Cat 3 codes 0994T and 0995T. While code 34701 is similar, it describes delivering a permanent endograft. In contrast, our new codes focus on a dual balloon catheter that delivers a novel drug therapy to stabilize the aortic wall. Also, while 34713 covers the same percutaneous access and closure we use, it does not account for the specialized stabilization drug itself. The lower extremity revascularization completely overhauled, restructured. So let's talk about the new approach to lower extremity coding. It really boils down to what vessel, how did you treat it, and how complex was it? First is an expansion to 4 territories, adding in everything below the ankle. Second, we need to clearly document lesion complexity. Was it straightforward or was it chronic total occlusion? And third, there is a clear treatment hierarchy. IVL is at the top, followed by atherectomy, stenting, and angioplasty. Documentation, and you will hear me say this more than once for talking about documentation in this section. If one lesion crosses into multiple vessels, that's just one code. If you have multiple lesions in one vessel, code for the most complex one. And finally, the new add-on logic helps us properly code for additional vessel treatments. For 2026, the iliac vascular territory covering the common, internal, and external iliac arteries is captured under the new 37254 through 37262 code set. These are just the same new codes. I do want to point out code 37262 is a new add-on specifically for intravascular lithotripsy or IVL in this territory. Documentation must clearly describe which vessels were treated, the approach, and the specific techniques performed to ensure accurate coding. Looking at codes 37263 through 37279, These cover the common femoral and popliteal territories. The big change for 2026 is how we define a vessel here. Previously, all four arteries in this area were bundled as one. Now the territory is split into two distinct billable vessels. First, the common femoral and profunda are grouped together, and the second, the SFA and popliteal, are treated as their own separate vessel. Again, documentation requirements. Just clear and detailed documentation that must specify specific vessels treated, approach, techniques, and details of imaging guidance. These are same, just the new codes. Same. Moving into the lower leg, we now use the 37280 through 37295 to define our work in the tibial and peroneal arteries. Just a quick documentation tip, treat the tibio-peroneal trunk as part of the distal vessels. You only report it separately if it is the sole vessel receiving an intervention. And that's just some more of the new codes for the tibial and peroneal vascular territory. We are now recognizing the inframallear area, which is the space below the ankle, as its own distinct fourth vascular territory. This is a major shift as it's now treated separately from the tibial and peroneal vessels. When we talk about this territory, we're specifically looking at dorsalis pedis and the plantar arteries. It's important to note that the pedal arch is now bundled into those vessels. You'd only report it separately if it is the only site you are treating. Finally, keep in mind that coding in the zone is limited to angioplasty only, with a maximum of 2 vessels reported. Just to start with a quick refresher, lithotripsy is the process of using energy to break up hardened masses, kind of like kidney stones, into small fragments so the body can pass them naturally. For the 2026 updates, we have 2 new add-on codes specifically for IVL. First is 37262, covers the IVL and the iliac artery, and you can report this up to 3 times per leg. And 37279 is the femoral and popliteal territories, and this one is limited to 2 units per leg, even if you are treating multiple vessels within that area. Moving on to urology. Let's look at the changes for laparoscopic radical prostatectomy in 2026. The main takeaway is a shift toward bundling lymph node dissection into primary procedure. Going forward, CPT 55866 is reserved exclusively for the prostatectomy alone. If you are performing a limited lymph node biopsy, you will now use 55868. And if you are doing a full bilateral pelvic lymphadenectomy, you will use 55869. For prostate biopsy services, we've moved away from the one-size-fits-all code of 55700. And we are going to use revised code 55705, which is strictly for non-imaging guided in-office needle punch procedures. New codes 55707 through 714. And this is categorized by approach, transrectal or transperineal, and imaging modality, which is ultrasound, MRI fusion, or NBOR. For targeted biopsies, you're going to report the code once per lesion. The number of individual cores taken from that lesion does not change the primary code. Add-on code 55715 will be used if you are targeting more than one lesion using fusion or NBOR guidance. And just documentation, you must now document the specific surgical approach and the exact imaging technology used. We now have a dedicated code for IRE of prostate 55877. This code is straightforward. It is reported only once, regardless of how many tumors are treated. Code 0600T has been revised and should now only be used for IRE ablation in other areas, in areas other than the liver or the prostate. For BPH, we are moving from Category 3 to a dedicated Category 1 code for Optolume procedure, and that would be code 52443. We are seeing the deletion of code 52647 for laser coagulation of the prostate. We have a new Category 1 code, 52597, specifically for aqua ablation. This is a major change because it is an all-inclusive code, and the old Category 3 code, 0421T, has been deleted. New code for percutaneous lumbar decompression, 62330, covers the initial interspace and is inherently bilateral. And for any additional levels treated in that same session, you'll use add-on code 62331. And these replace the old Category 3 code 0275T for lumbar procedures. And just some Category 3 codes. 0950T is used to report US of high intensity focused ultrasound to ablate benign prostate tissue. Differs from code 55880, which is used to report ablation of malignant prostate tissue. Codes 0988T and 89T have been established to report subcutaneous and subfacial insertion or replacement of integrated tibial nerve stimulators. Code 0991T covers the use of low pressure ultrasound or lithotripsy to treat ureteral stones. 1000T is used to report autologous muscle progenitor cell injections into the urethral sphincter. Code 0992T through 3T describe AI-powered analysis of perivascular fat on coronary to assess risk. Code 0999T through 1001T have been added to report autologous muscle cell therapy. Code 1012T is for motorized trephination of the sclera or trabecular meshwork involving a short incision through the limbus. 0599T has been updated to mirror changes in its primary code of 0598T, which was revised to remove non-contact requirements. Category 3 code 0275 described percutaneous laminotomy, laminectomy for lumbar decompression is replaced by new Category 1 code 62330 and 62331. That was a lot. As you can see, the 2026 CPT updates, they focused heavily on digital health, AI integration, and major overhauls. Like I said, it was a heavy lift for this year. Here are the references. Everything that I have talked about, you can find here, AMA website, CMS website. And thank you all for participating. I think now we will open it up to some questions.
Great. Thank you, Heather, for that very informative and long session. We do have a couple questions. The first question is, how should providers handle payer variability or delayed adoption of new 2026 CPT codes to minimize claim denials?
Excuse me. I would hold the claims until the systems are updated. That would cut back on your denials and delayed revenue. I would just hold the claims until the systems are updated.
Okay, great. Next question. For new code 99470, remote patient monitoring, how do you capture minutes 1 through 9?
You do not. Those are actually non-billable. Anything less than 10 minutes is not billable. So those are, maybe eventually they will add a code that covers that. But as for right now, there are no codes that you can bill that with.
Great. And then for scalp cooling, is this billed each chemo session or once per chemo plan?
Well, they are both. So the 97001 is once per chemo treatment period, because that is like the scalp fitting and everything. That's something you're only going to do once. The 97008 through 9 is per chemo session. So the 7 is per chemo treatment period, and 8 and 9 are per chemo session.
And then looks like the last question we have is what defines a complex lesion in the 37261 add-on code?
So the complex lesions are generally defined as 100% blockage. So there is absolutely no blood flow. So just 100% blockage.
Great, thank you.
Okay, Julie, were there any other questions?
No other questions.
All right, perfect. Well, that brings us to the end of today's webinar inside the 2026 CPT updates. And on behalf of Kohler Healthcare Consulting, we thank you for joining us today and for your engagement throughout the session. A special thank you to our speaker, Heather Dunlap, for sharing her time, expertise, and insights, as well as our Kohler team for helping with building questions and just the setup for today's webinar. We also appreciate everyone, again, who submitted questions. If you didn't get your question answered, our team will review them and follow up as appropriate. You'll see a brief post webinar survey later this week. We truly appreciate your feedback. It helps us continue to improve and shape future programming. You'll also receive a follow-up email with a link to this recording, the presentation materials, and information about our upcoming webinars hosted by Kohler Healthcare. We encourage you to keep an eye out in your inbox and stay connected for future educational opportunities. And again, thank you for spending your time with us today. Have a great rest of your day.